Hello, everyone. So, we will be starting with chapter 10 of Illustrated Textbooks of Pediatrics. Chapter 10 is about perinatal medicine. Features of perinatal medicine are good pregnancy and neonatal outcomes depend on good maternal health and care. Non-invasive antenatal diagnosis is reducing the risk of fetal loss from invasive tests. Maternal viral infection during pregnancy can seriously affect the fetus. Worldwide prematurity is the leading cause of mortality in children less than 5 years old. When required, newborn resuscitation can be achieved with simple measures. In most instances, newborn infants have a number of assessments shortly after birth, routine examination, hearing and biochemical screening, and increasingly oxygen saturation screening for critical congenital heart diseases. The term perinatal medicine refers to the medical care of the fetus and infant, particularly those with complex problems before, during, and after birth, acknowledging the continuity of fetal and neonatal life. Using modern technologies such as high resolution ultrasound, magnetic resonance imaging, and DNA analysis, detailed information about the fetus can now be obtained for a large and increasing number of conditions. Close cooperation is important between the professional involved in the care of pregnant mother and fetus and those caring for the newborn infants. Some definitions used in perinatal medicines are listed in the box. 10.1 Box 10.1 shows some definitions. Commonly used terms in perinatal medicine: stillbirth, fetus born with no signs of life, more than or equal to 24 weeks of pregnancy, perinatal mortality rate, stillbirths plus death within the first week per 1,000 live births, and stillbirths. Neonatal mortality rate, deaths of live born fetus within the first 4 weeks after birth per 1,000 live births. Neonate is infant less than 28 days old. Preterm is gestation less than 37 weeks of pregnancy. Term is 37 to 41 weeks of pregnancy. Postterm is gestation for more than or equal to 42 weeks of pregnancy. Low birth weight is less than 2,500 gram. Very low birth weight is less than 1,500 gram. Extremely low birth weight is less than 1,000 grams. Small for gestational age is birth weight less than 10th centile for gestational age. Large for gestational age, birth weight more than 90th centile for gestational age. Pre-pregnancy care: the better a mother's state of health and nutrition and the higher her socioeconomic living standard and the quality of healthcare she receives, the greater the likelihood of a successful outcome to her pregnancy. Couples planning to have a baby often ask what they should do to optimize their chances of having a healthy child. They can be informed that for the mother, smoking reduces birth weight, which may be of critical importance if born preterm. On average, the babies of smokers weigh 170 grams less than that of non-smokers, but the reduction in birth weight is related to the number of cigarettes smoked per day. Smoking is also associated with increased risk of miscarriage in stillbirth. The infant has a greater risk of sudden infant death syndrome. Now, pre-pregnancy folic acid supplements reduce the risk of neural tube defects in the fetus. Low-dose folic acid supplementation is recommended for all women planning a pregnancy. A high dose is recommended for women at increased risk of neural tube defects if they have had or have a close relative with a previously affected fetus or have diabetes or are using certain anticonvulsants. Pre-existing medical conditions such as diabetes, epilepsy, or hypertension must be reviewed and monitored and management changed if necessary. Certain medications such as retinoids, warfarin, and sodium valproate should be avoided because of teratogenic effects. Alcohol ingestion and drug abuse, opiates, cocaine, may damage the fetus. Congenital rubella is preventable by maternal immunization before pregnancy. Exposure to toxoplasmosis should be minimized by avoiding eating undercooked meat and by wearing gloves when handling cat litter. Listeria infection can be acquired from eating unpasteurized dairy products, soft ripened cheese, for example, brie, camembert, and blue veined varieties, pate, and ready-to-eat poultry, unless thoroughly reheated. Eating liver during pregnancy is best avoided as it contains a higher concentration of vitamin A. Avoid eating swordfish and limit tuna because of high levels of mercury. Limit oily fish intake as may contain pollutants. Any obstructive risk factors for complications of pregnancy or delivery, for example, recurrent miscarriage or previous preterm delivery, should be identified, treated, or monitored. Maternal obesity is associated with an increased risk of miscarriage, gestational diabetes, and pregnancy-induced hypertension. Babies of obese mothers are at risk of stillbirth, congenital abnormalities, macrosomia, and neonatal mortalities. In addition, the children of obese mothers are more likely to be obese themselves and develop metabolic disorder associated with this. Couples at increased risk of inherited disorder should receive genetic counseling before pregnancy. They can then be fully informed, decide whether or not to proceed, and consider antenatal diagnosis if available. Pregnancy at increased risk of fetal abnormality include those in which the mother is older. If she is more than 35-year-old, the risk of Down syndrome is more than 1 in 380. Although screening is now available for all mothers, there is a previous congenital abnormality. There is a family history of inherited disorder. The parents are identified as carriers of an autosomal recessive disorder, for example, thalassemia. A parent carries a chromosomal rearrangement. Parents are close blood relatives. Consanguinity. Bullet point is pre-pregnancy folic acid supplements reduce the risk of neurogenic defects in the fetus. Now, the antenatal diagnosis has become available for an increased number of disorders. Screening tests performed on maternal blood and ultrasound of fetus are listed in box 10.2, which we will see later. The main diagnostic techniques for antenatal diagnosis are maternal serum screening and detailed ultrasound scanning. More specialized techniques are chorionic villus sampling, fetal blood sampling, amniocentesis, and non-invasive prenatal testing. In some rare conditions, pre-implantation genetic diagnosis allows genetic analysis of cells from a developing embryo before transfer to the uterus. The structural malformations and other lesions that can be identified on ultrasound are listed in box 10.1 with an example in the figure. 10.2, antenatal screening for disorders affecting the mother fetus allows reassurance where disorders are not detected. Optimal obstetric management of the mother and fetus, interventions for a limited number of fetal conditions such as relieving bladder obstruction or draining pleural effusion to improve perinatal outcome. Counseling and neonatal management to be planned in advance. The option of termination of pregnancy to be offered for several disorders affecting fetus or compromising maternal health. Parents require accurate medical advice and counseling to help them with these difficult decisions. Many transient or minor structural disorders of the fetus are also detected may cause considerable anxiety. Antenatal diagnosis allows many congenital malformation which used to be diagnosed at birth or during infancy to be identified before birth. Fetal medicine, the fetus can sometimes be treated by giving medication to the mother. Examples are glucocorticoid therapy before preterm delivery accelerates lung maturity and surfactant production. This has been tested in over 15 randomized trials and markedly reduces the incidence of respiratory distress syndrome, relative risk 0.66, and intraventricular hemorrhage. Relative risk is 0.54, and neonatal mortality, which is relative risk, is 0.69. In preterm infants, for optimal effect and completed course, need to be given at least 24 hours before delivery. Digoxin and flecainide can be given to the mother to treat fetal supraventricular tachycardia. Now this box shows all the screening tests for antenatal diagnosis, maternal blood group and antibodies for rhesus and other red cell incompatibilities, hepatitis B, syphilis, rubella, HIV infections, neurotube effects, raised maternal serum alpha 14 with spina bifida and encephaly, while ultrasound alone increasingly used. Down syndrome trisomy 21, Edwards syndrome trisomy 18, Patau syndrome is trisomy 13. Risk estimate calculated for maternal age and maternal and fetal-placental hormones. This is combined with ultrasound screening for nuchal translucency, back of neck, and confirmed with amniocentesis chorionic sampling detects 90% of with Down syndrome, but 3 to 5% false positive rate and 1% risk of fetal loss. Alternatively, identification by non-invasive prenatal testing is increasingly available and scheduled as routine screening tests in UK. Ultrasound screening gestation age can be estimated reliably if early in pregnancy. Multiple pregnancy can be identified. Structural malformation, up to 80% of major congenital malformation can be detected. If a significant abnormality is suspected, more detailed scan by specialist is indicated. Fetal growth can be monitored by serial measurements of abdominal circumference, head circumference, and femur length, supplemented with Doppler ultrasound umbilical and fetal flow velocity waveform measurements if indicated. Amniotic fluid volume oligohydramnios will result from reduced fetal urine production because of dysplastic or absent kidneys or obstructive uropathy from prolonged rupture of the membranes or may be associated with severe intrauterine growth restriction. It may cause pulmonary hyperplasia and limb and facial deformities from pressure on the fetus, that is, Porter sequence. Porter syndrome. Polyhydramnios, this is associated with maternal diabetes and structural gastrointestinal abnormalities, for example, atresia in the fetus. This figure shows some of the technique used for antenatal diagnosis. The first one is amniocentesis, chromosome microRNA DNA analysis, fetal infection, uses PCR, fetal blood sampling, fetal hemoglobin for anemia, fetal infection serology, fetal blood transfusion, chorionic venous sampling for chromosome microarray and DNA analysis, fetal infection is PCR, enzyme analysis of in-one error of metabolism. Pre-implantation genetic diagnosis, PGD, in vitro fertilization allows genetic analysis of cells from developing embryo before transfer to the uterus. Fetoscopy is minimally invasive surgery, laser photocoagulation of communicating vessels in twin-twin transfusion syndrome. Non-invasive prenatal testing, cell-free chorionic free fetal DNA, CFF DNA from maternal blood, identification of Down syndrome, other chromosome disorders, fetal gender, and rhesus status. Now it shows box 10.3 shows main structural malformations and other lesions detectable by ultrasound. In CNS, it shows anencephaly, always detected, spina bifida, hydrocephalus, microcephaly, and cephalocele. Cardiac, about 50% of severe malformations detected on routine screening, over 90% at specialist centers. Intrathoracic, diaphragmatic hernia, congenital cystic adenomatoid lung formation, CCAM, and esophageal atresia, facialis cleft lip. GIT has bowel obstruction, for example, duodenal atresia, exomphalos, and gastrospices. Genitourinary dysplastic or cystic kidney, obstructive disorder of kidneys or urinary tract, hydronephrosis, distended bladder, skeletal dysplasia, for example, achondroplasia and limb production deformities, hydropsis, edema of the skin, pleural effusion, and ascites, chromosomal Down syndrome, suspected from thickened back of neck, nuchal translucency, duodenal atresia, or an AV canal defect of the heart, other chromosome disorders from identifying multiple abnormalities. Examples of antenatal diagnosis: gastroschisis. Gastroschisis is antenatal ultrasound showing free loops of bowel in amniotic fluid and following delivery. Antenatal diagnosis allowed the baby to be delivered at a pediatric surgical unit and the parents to be forewarned about the need of surgery. Satisfactory surgical repair was achieved. Now, the case history: antenatal diagnosis: routine ultrasound scan at 18 weeks of gestation identified as abnormal lemon-shaped skull. This, together with the abnormal appearance of cerebellum, is an Arnold-Chiari malformation, which is associated with spina bifida. An extensive spinal defect was confirmed on ultrasound. Dilatation of the cerebral ventricles, telepice equinovarus, already present in this fetus, suggested a severe spinal lesion. After counseling, the parent decided to terminate the pregnancy. There are a few conditions which therapy can be given to the fetus directly. Rhesus isoimmunization: severely affected fetuses become anemic and may develop hydrocephalus with edema and ascites. Infants at risk are identified by maternal antibody screening. Regular ultrasound of fetus is performed to detect fetal anemia non-invasively using Doppler velocimetry of the fetal middle cerebral artery. Fetal blood transfusion via the umbilical vein may be required regularly from about 20 weeks gestation. The incidence of rhesus hemolytic disease has fallen markedly since anti-demonization of mothers was introduced, but hydrocephalus is still seen due to other red cell antibodies such as KEL. Perinatal isoimmune thrombocytopenia. This condition is analogous to rhesus isoimmunization but involves maternal antiplatelet antibodies crossing the placenta. It is rare, affecting about 1 in 5,000 births. Intracranial hemorrhage secondary to fetal thrombocytopenia occurs in up to 25% of cases. The problem may be anticipated if there was a previously affected infant when prenatal intravenous immunoglobulin and maternal glucocorticoid therapy can be given. Maternal glucocorticoid therapy before preterm delivery markedly reduces morbidity mortality in the neonates. Fetal surgery. Fetal surgery, relatively new development with varying results. Procedures that have been performed include catheter shunts inserted under ultrasound guidance. This is to drain fetal pleural effusions. Pleuroamniotic shunts, often from a chylothorax, lymphatic fluid, or congenital cystic adenomatous malformation of the lung. One end of a looped catheter lies in the chest and other end in the amniotic cavity. Procedure works well. Outcome depends on underlying problem. Laser therapy to ablate placental anastomosis, which leads to twin transfusion syndrome. Intrauterine shunting for obstruction to urinary outflow, as with posterior urethral walls, but does not appear to improve outcome. Careful case selection and follow-up are required to ensure that these novel forms of treatments are of long-term benefit. Now, obstetric conditions affecting the fetus: preeclampsia. Mothers with preeclampsia may require preterm delivery because of the maternal risk of eclampsia and cerebrovascular accident, or the fetal risk associated with placental insufficiency and growth restriction. Determining the optimal term for preterm delivery requires an evaluation of the risk to the mother and fetus of allowing the pregnancy to continue compared with the neonatal complication associated with preterm birth. Now, placental insufficiency and intrauterine growth restriction. Fetal growth may be progressively restricted because of placental insufficiency. Transfer of oxygen and nutrients is reduced. The growth restricted fetus will need to be monitored closely to prevent intrauterine death. This is done by measuring growth parameters: the biophysical profile, amniotic fluid volume, fetal movement, fetal tone, fetal breathing movements, and fetal heart activity, and Doppler blood flow velocity, umbilical and middle cerebral arteries. Absence or reversal of flow velocity during diastole carries an increased risk of morbidity from hypoxic damage to the gut or brain, or of intrauterine death. These measurements assist in deciding the optimal time for delivery of a growth restricted fetus. Preterm delivery in the UK, 7.2% of births were preterm in 2012. However, only 5.9% of births in Sweden and Japan were preterm, but 11.5% in the US. Neonates may be born preterm following spontaneous labor with intact membranes, 40 to 50%. Preterm premature rupture of membranes, 25 to 30%. Labor induction or cesarean section for maternal or fetal indications, 30 to 35%. Main causes are shown in figure 10.4. There are many epidemiological risk factors, presumably responsible for the wide inter-country variation in prematurity rate, but they're poorly understood. Factors that increase the risk of preterm delivery include previous preterm infant, a short interpregnancy interval, less than 6 months, maternal age, less than 20 or more than 35 years, obesity, ethnicity, for example, higher in Black mothers, multiple births influenced by assisted reproduction practices, maternal infection, smoking and substance misuse, and maternal psychological or social stress. The management of preterm labor may involve antenatal corticosteroids, antibiotics to reduce risk of chorioamnionitis, and neonatal infection for preterm premature rupture of the membranes, tocolysis to suppress uterine contractions to try and suppress labor and allow completion of course of antenatal steroids. Magnesium sulfate may be given as studies show it reduces the incidence of cerebral palsy. However, its mode of action is unknown. In utero, transfer to a center appropriate for care of the preterm baby. So this is a figure which causes of prematurity, IUGR, which is preterm delivery, is intrauterine infection, chorioamnionitis, bacterial vaginosis, preterm prolonged rupture of membranes, fetus IUGR, congenital malformation, maternal medical conditions, preeclampsia, hypertension, chronic medical conditions, UTI, cervical weakness. And then it is idiopathic, intrauterine stretch, multiple gestation, polyhydramnios, uterine abnormalities, endocrine maturation, premature onset of labor, intrauterine bleeding, abruption, and antepartum hemorrhage. The aim is to prolong pregnancy for as long as possible whilst ensuring that the condition of the mother and fetus is not compromised. The mode of delivery needs to be planned and arrangements made for the infant to receive the required level of care. The care of preterm infants is described in the next chapter. Now, multiple births. Twins occur naturally in the UK in about 1 in 90, triplets in 1 in 8,000, quadruplets in 1 in 7 lakh deliveries. In recent years, number of triplets and higher order births have more than doubled, mainly from assisted reproduction programs and advancing maternal age. 1 in 64 births is now multiple birth. Although the number of multiple births has recently declined in UK, mainly as a result of limiting embryo transfers following in vitro fertilizations. The main problem for the infant associated multiple births are preterm labor. The median gestation twins is 37 weeks, for triplets 34 weeks, and for quads 32 weeks. Preterm delivery is the most important cause of the greater perinatal mortality of multiple births, especially for triplet and higher order pregnancies. When a higher order pregnancy is identified, embryo reduction may be offered. Intrauterine growth restriction. Fetal growth is one or more fetuses may deteriorate and needs to be monitored regularly. Congenital abnormalities, these occur twice as frequently as in a singleton, but the risk is increased fourfold in monochorionic twins. Shared placenta, twin-twin transfusion syndrome in monochorionic twins may cause extreme preterm labor, fetal death, and discrepancy in growth. Complicated deliveries due to malpresentation of the second twin at vaginal delivery, finding sufficient intensive care cots in the same neonatal intensive unit for preterm multiple births can be problematic. Although multiple births may look endearing, The families may need additional assistance and support. Feeding often possible to breastfeed twins, usually not possible for higher order births. Practical with their care and housework requires about 200 hours per week for triplets in infancy and going out. Emotional and physical exhaustion, loss of privacy as a couple, increased rates of separation and divorce, additional financial costs, increased behavioral problems in the infants and their siblings, while being a multiple birth may provide companionship, affection, and stimulation between each other. It may also engender domination, dependency, and jealousy. There are local and national support groups for parents of multiple births. Now, the summary, multiple births have markedly increased over the last 20 years associated with an increased risk of prematurity, IOGR, congenital malformation, twin transfusion syndrome in monochorionic twins, are responsible for 30% of a very low birth weight infants, less than 1.5 kg birth weight, provides many additional difficulties for their parents to care for them. Now, the maternal conditions affecting the fetus, diabetes mellitus, women with insulin-independent diabetes find it more difficult to maintain good diabetic control during pregnancy and have an increased insulin requirement. Poorly controlled maternal diabetes is associated with polyhydramnios and preeclampsia, increased rate of early fetal loss, congenital malformation, and late unexplained intrauterine death. Ketoacidosis carries a high fetal mortality rate. With meticulous attention to diabetic control, the perinatal mortality rate is now only slightly greater than in non-diabetics. The National Institute of Healthcare Excellence, that is NICE, has produced guidelines on the management of diabetes and complications from preconception to the postnatal period. The emphasis is on aiming for good control of blood glucose. Fetal problems associated with maternal diabetes are congenital malformations. Overall, there is a 6% risk of congenital malformations, a threefold increase compared with the non-diabetic population. The range of anomalies similar to that for the general population, apart from an increased risk of cardiac malformation, sacral agencies, caudal regression syndrome, and hyperplastic left colon. Although the latter two conditions are rare, studies show that good diabetic control conceptually reduces the risk for congenital malformations, IOGR. There is a threefold increase in growth restriction in mothers with long-standing microvascular disease. Macrosomia, maternal hyperglycemia, causes fetal hyperglycemia as glucose crosses the placenta and insulin does not cross the placenta. The fetus responds with increased secretion of insulin, which promotes growth by increasing both cell number and size. About 25% of such infants have a birth weight greater than 4 kg, compared with 8% non-diabetes. The macrosomia predisposes to cephalopelvic disproportion, birth asphyxia, shoulder dystocia, and brachial plexus injury. Neonatal problems include hypoglycemia. Transient hyperglycemia is common during the first day of life from fetal hyperinsulinism, but can often be prevented by early feeding. The infant blood glucose should be closely monitored during the first 24 hours and hypoglycemia treated. Respiratory distress syndrome more common as lung maturation is delayed. Hypertrophic cardiomyopathy, hypertrophy of the cardiac septum occurs in some infants. It regresses over several weeks but may cause heart failure from reduced left ventricular function. Polycythemia, venous hematocrit more than 0.65 makes the infant look plethoric. Treatment with partial exchange transfusion to reduce the hematocrit and normalized viscosity may be required if symptomatic. Gestational diabetes is when carbohydrate intolerance can occur only during pregnancy. It is more common in women who are obese and those of Black and Asian ethnicity. The incidence of macrosomia and its complications similar to that of insulin-dependent diabetic mother, but the incidence of congenital malformation is not increased. However, there are an increasing number of Mothers with type 2 insulin dependent diabetes mellitus associated with the increase in obesity in the population. The fetus is also at increased risk of congenital malformations. Now, the summary: maternal diabetes, meticulous control preconceptually and during pregnancy, markedly reduces fetal neonatal morbidity and mortality. The fetus may be macrosomic because of fetal hyperglycemia, resulting in hyperinsulinism and growth restriction. Secondary to maternal microvascular disease and is at an increased risk of congenital malformations. The macrosomic infant is at an increased risk of birth asphyxia and birth trauma from obstructive labor or delivery. The newborn infant is prone to hypoglycemia and polycythemia. Next is hypothyroidism. If mother have or have had grave disease, 1 to 2% of newborn infants are hyperthyroid. This is due to circulating thyroid stimulating immunoglobulin, which is called TSH receptor antibody, TSHR antibody, which crosses the placenta and binds to TSH receptors, stimulating fetal thyroid hormone production. Hypothyroidism in fetus is suggested by fetal tachycardia on the CTG trace, and fetal goiter may be evident on ultrasound. In the neonate, it is suggested by irritability, weight loss, tachycardia, heart failure, diarrhea, and exophthalmos in the first 2 weeks of life. Treatment with antithyroid drug may be necessary for several months until the condition resolves. Now, SLE with antiphospholipid syndrome is associated with recurrent miscarriage, IOGR, preeclampsia, placental abruption, and preterm delivery. Some of the infants born to mothers with antibody to Rho and La, SSA, and SSB antigens, ALE, develop neonatal lupus syndrome, in which there is a self-limiting rash and rarely heart block. Autoimmune thrombocytopenic purpura and autoimmune maternal autoimmune thrombocytopenic purpura AITP. The fetus may become thrombocytopenic because of maternal IgG antibodies cross the placenta and damage fetal platelets. Several fetal thrombocytopenia places the fetus at risk of intracranial hemorrhage following birth trauma. Infants with severe thrombocytopenia petechiae at birth should be given intravenous immunoglobulins. Platelet transfusion may be required to reduce the risk of intracranial hemorrhage or if there is acute bleeding. Maternal drugs affecting the fetus. Relatively few drugs are known definitely to damage the fetus, but it's clearly advisable for pregnant women to avoid taking medicine unless it is essential. While the teratogenicity of a drug may be recognized if it causes severe and dissection malformation, as with limb shortening following thalidomide ingestion, milder and less distinctive. Abnormalities may go unrecognized. Selective serotonin reuptake inhibitors, SSRIs, are an example of this. They have been found to be associated with increased risk of persistent pulmonary hypertension of the newborn. Caution must be taken with all the new drugs. Studies on pregnant women will be limited, and the recognition or emergence of teratogenic effects may be delayed. Alcohol and smoking, excessive alcohol ingestion during pregnancy is sometimes associated with fetal alcohol syndrome. Its clinical features are growth restriction, characteristic face, a developmental delay and cardiac defects up to 70%. Effects of less severe ingestion and binge drinking remain uncertain but may affect growth and development, and mothers are advised to avoid alcohol. Development of Health UK, maternal cigarette smoking is associated with increased risk of miscarriage and stillbirth, a reduction in birth weight, and IOGR. So this picture shows characteristic faces of fetal alcohol syndrome with a saddle-shaped nose, maxillary hyperplasia, absent fulcrum between the nose and upper lip, and short and thin upper lip. The child also has a strawberry nevus below the right nostril. Now, the maternal medication that may adversely affect the fetus: anticonvulsant therapy with carbamazepine, valproic, sodium valproate, and hydrantoins. Fetal carbamazepine, valproate, hydrantoin syndrome with facial hypoplasia, CNS, limb and cardiac malformations and developmental delay, cytotoxic agents, congenital malformation, iodized propyl thyrouracil, goiter, and hypothyroidism, lithium, congenital heart disease, selective SSRIs, or persistent pulmonary hypertension in the newborn, tetracycline, enamel hyperplasia of the teeth, and thalidomide, limb shortening, phocomelia, and vitamin A and retinoids increase high spontaneous abortions, abnormal face. Warfarin interferes with cartilage formation, nasal hypoplasia, and epiphyseal stippling, cerebral hemorrhages, and microcephaly. The next is drug abuse. Maternal drug abuse with opiates associated with increased risk of prematurity and growth restriction. Many narcotic abusers take multiple drugs. Infants of mother abusing heroin, methadone, and other opiate during pregnancy often show evidence of drug withdrawal with jitteriness, sneezing, yawning, poor feeding, vomiting, diarrhea, weight loss, and seizures during the first 2 weeks of life. Cocaine abuse associated with placental abruption preterm delivery, but rarely with withdrawal in the infant, although it may result in irritability and tremor in the first few days of life. Amphetamine abuse is also associated with GIT and cerebral infarction. Mothers with abuse who abuse drugs and their infants are also at risk of Hep B, C, and HIV infections. Hep B vaccine is given to babies when indicated. Social and child protection aspects must be considered and social services involved. Infants who develop significant feature of drug withdrawal require treatment, usually with an oral opiate, morphine sulfate, and often need to be admitted to the neonatal unit. One of the major problems in managing these infants is that the parents' lifestyle and temperament are often not conducive to the needs of the babies and young children. Close supervision or alternative caregivers are often required. If there are unexplained clinical signs in an infant, consider drug withdrawal. Drugs given during labor, potential adverse effect drugs given during labor on the fetus are opioid analgesics and anesthetic agents may suppress respiration at birth. Epidural anesthesia may cause maternal pyrexia during labor. It is often difficult to differentiate this from fever caused by an infection. There's an increase in the rate of assisted deliveries. Sedatives, for example, diazepam may cause sedation, hypothermia, and hypotension in the newborn. Oxytocin and prostaglandin F2 may cause hyperstimulation of the uterus, leading to fetal hypoxia. It is also associated with a small increase in bilirubin levels in the neonate. Intravenous fluids may cause neonatal hyponatremia unless they contain an adequate concentration of sodium. Now, congenital infections. Intrauterine infection is usually from maternal primary infection during pregnancy. Those that can damage the fetus are rubella, CMV, and Toxoplasma gondii, parvovirus, varicella zoster, and syphilis. So, in the picture shown congenital infections, cataract from congenital rubella, congenital heart disease, and deafness are other common defects. Clinical features of congenital rubella, cytomegalovirus, and toxoplasmosis and syphilis, growth restriction, eye defects, cataracts, microphthalmia, retinitis, pneumonitis, hepatomegaly, jaundice, hepatitis, virus in urine, rubella and CMV, bone abnormalities, intracerebral calcification, hydrocephalus, microcephalus, deafness, heart defects, cardiomegaly, patent ductus arteriosus, splenomegaly, rash, blueberry muffin or petechial, anemia, neutropenia, thrombocytopenia. The rubella, the diagnosis of maternal infection must be confirmed serologically as clinical diagnosis is unreliable. The risk and extent of fetal damage are mainly determined by the gestational age at the onset of maternal infection. Infection before 8 weeks gestation causes deafness, congenital heart disease, and cataracts in over 80% of cases. As shown in the picture, about 30% of fetuses of mother infected at 13 to 16 weeks gestation have impaired hearing. Beyond 18 weeks to the fetus is minimal. Viremia after birth continues to damage the infant. Tests used to confirm the diagnosis are shown in the box. Confirmation of diagnosis of congenital rubella, cytomegalovirus, torch infections are mother seroconversion on screening serology, for fetus, amniocentesis or chorionic sampling, polymerase chain reaction, placenta microscopy for syphilis, PCR, urine from infant, rubella, CMV, culture and PCR, blood tribosine food and other samples for infant culture and PCR, and blood serology, rubella specific IgM, CMV specific IgM, toxoplasma specific IgM, and persistently raised toxoplasma IgG. The range of clinical feature characteristics of congenital infection is shown in 10.7b. Shown. Congenital rubella is preventable. In the UK, it has become extremely rare since the measles, mumps, rubella vaccine were introduced into the childhood immunization program, but this is dependent on the maintenance of a high vaccine uptake rate. Cytomegalovirus is the most common congenital infection affecting 0.5 per thousand to 1 by 1,000 live births in the UK. In Europe, 50% of pregnant women are susceptible to CMV. About 1% of susceptible women will have a primary infection during pregnancy, and in about 40% of them, the infant becomes infected. The infant may also become infected following an episode of recurrent infection in the mother, but this is much less likely to damage the fetus. When an infant is infected, 90% are normal at birth and develop normally. 5% have clinical features at birth, such as hepatosplenomegaly and petechiae, most of whom will have neurodevelopmental disabilities such as sensorineural hearing loss, cerebral palsy, and epilepsy and cognitive impairment. 5% develop problems later in life, mainly sensorineural hearing loss. Infection in the pregnant woman is usually asymptomatic or causes mild, non-specific unless there is no CMV vaccine and pregnant women are not screened for CMV. Early treatment with antiviral therapy, for example, Janciclovir, for infants with sensorineural hearing loss, central nervous system involvement can reduce the adverse impact on sensorineural hearing loss and long-term neurodevelopment. Next is a toxoplasmosis, acute infection with T1 dye, protozoan parasite may result from consumption of raw and undercooked meat or from contact with the feces of recently infected cats. In the UK, fewer than 20% pregnant women have had past infection, in contrast to 80% France and Austria. Transplacental infection may occur during the parasitemia of the primary infection, and about 20% fetuses become infected. In the UK, incidence of congenital infection is only 0.1 per thousand live births. Most infected infants are asymptomatic. About 10% of clinical manifestation of which the most common are retinopathy and acute fundal chorioretinitis, which sometimes interferes with vision, cerebral calcification, hydrocephalus. These infants usually have long-term neurological disabilities. Infected newborn infants are usually treated pyrimethamine and sulfadiazine for 1 year. Asymptomatic infants remain at risk of developing chorioretinitis into adulthood. Varicella zoster. A total of 15% of pregnant women are susceptible to varicella chickenpox. Usually, the fetus is unaffected but will be at risk if the mother develops chickenpox in the first half of pregnancy, less than 20 weeks, when there is less than 2% risk of fetus developing severe scarring of the skin and possibly ocular and neurological damages and digital dysplasia within 5 days before or 5 days after delivery, and the fetus is unprotected by maternal antibodies and the viral dose is high. About 25% develop a vesicular rash. The illness has a mortality as high as 30%. Exposed susceptible mothers can be protected with varicella zoster immunoglobulin and treated with a cyclovir. Infant born in the high risk period should also receive zoster immunoglobulin and are closely monitored and given a cyclovir if any signs of infection develop. If a mother develops chickenpox shortly before or after delivery, the infant needs protection from infection. Now, syphilis. Congenital syphilis is rare in the UK. Clinical features are shown in figure 10.7b. Those, as shown in the previous picture, those specific to congenital syphilis include a characteristic rash on the soles of feet and hands and bone lesions. If mother's syphilis identified on antenatal screening are fully treated 1 month or more before delivery, the infant does not require treatment and has an excellent prognosis. If there is any doubt about the adequacy of maternal treatment, the infant should be treated with penicillin.